Hello, everyone. Today, I'm going to start a series of lecture based on child psychiatry. This is our first topic within those series of lecture, and the theme for today's lecture is going to be neurodevelopmental disorder in child and adolescent population. Now, the term neurodevelopmental disorder tells us that the onset of these disorders are going to be in the early developmental period, during the early stages. The presentation is going to be during early childhood or early adolescent. Most of the time, these disorders are going to be manifested before child enters school. Now, it is important to note, however, that some of these disorders discussed in this lecture may appear later in life. And the opposite is also true. You may see some of the disorders that we often see in adult population that can be seen in pediatric population as well. For example, bipolar, substance use, schizophrenia, those disorders are usually diagnosed in adult psychiatry. However, symptoms may present early on. And definitely some other disorders such as depression, anxiety, OCD, and so forth that we usually diagnose in adult population. Um, your child may present those symptoms early on. And of course, the opposite is also true. Symptoms such as, or the disorders such as ADHD, which is usually diagnosed during childhood and adolescent stage. But you may have an adult patient that was diagnosed later on, maybe in late 20s, early 30s, and so forth. All right. Um, another interesting point about child psychiatry is that these symptoms frequently co-occur with other disorders. For example, you may have a client with autism spectrum disorder, ASD, and they may have a co-occurrence with intellectual disability, which we will talk in a minute. The second example I have is individual with ADHD may also have some other comorbidity, if you will, either ASD or some other specific learning disorders. All right. As far as epidemiology and etiology is concerned, it is estimated that about 5 to 15% of children will experience some kind of psychiatric disturbances severe enough that they will need some kind of medical treatment, medical management. Unfortunately, many children will go undiagnosed or untreated. Children are affected differently by these disorders. It is very rare that a child will pick up the phone and make an appointment to see their healthcare providers regarding anxiety or depression. Well, even with the adult population, it's very, very difficult to really talk about mental health, but just multiply that issue, by thousands, if you will, if you have the same symptoms in pediatric population. The first issue is really inability to express. It's very difficult for child to even express how they feel as far as anxiety. They don't have that verbiage or that experience yet. That makes it very, very unique population. The major psychiatric illnesses seen in adults, such as depression, mania, anxiety, OCD, and so forth, are also seen in children. We talked about that, as mentioned earlier, that symptoms can manifest anytime in individual lifespan. So clinicians, the point I'm trying to make here is that clinicians should be ready to have a conversation with the client of any disorder, even if it is not normally present in that population. And one example I have is ADHD. Even the onset is early childhood, but it can be diagnosed later. As a matter of fact, I have a lot of clients I do adult psychiatry inpatient, and I do see a lot of clients with ADHD that should have been diagnosed a long time ago, and then or they got missed. We'll talk about that later on. All right. As far as etiology is concerned, there are many factors. You really cannot, most of the time, you can't really pinpoint to one factor, but we believe genetic overall plays a very important role. Some kind of either mutation or chromosomal changes or defect can manifest as a mental illness. Brain malformation during the child developmental stages, during pregnancy or during perinatal complications, um, you know, some kind of exposure, perhaps either during pregnancy or after, exposure to toxin, maybe lead, mercury, and perhaps some medications can cause that as well. Some other issues during the early child developmental stages, such as infections, seizures. I think any type of a brain trauma, traumatic brain injury, can result in some kind of a neurodevelopmental disorders. And of course, environment plays a very important role, overall patient safety and so forth. Remember, I mentioned, I believe last time as well, that I truly believe that all of us are genetically prepared or loaded for any kind of illness, and it is the environment that really pull that trigger. I give example, the gun is fully loaded, so that fully loaded gun is like a genetic, and environment is going to pull that trigger one day. So that's why we spend a lot of time and energy talking about a patient, make sure they are in a safe environment. All right, so today's lecture is going to follow this slide, if you will. DSM talks about 7 different types of neurodevelopmental disorder. So I listed these, and we will talk one at a time. The first one on the list is intellectual developmental disorder. Second is communication disorder. Number 3 is autism spectrum disorder, ASD. And number 4 is ADHD. Number 5 specific learning disorder. Number 6 motor disorder. And number 7 is other. All 7 of them are of course important, but from academia standpoint of view, from exam and standpoint of view, or the type of population that we serve, some topics are going to get more attention than the other. So I am going to spend more time on ASD and ADHD, and some other topics I'm going to just introduce. You feel free to contact me if you need more information on any of these topics. All right, so let's start with the number 1. So the first one on the list is intellectual developmental disorder. Now, the idea behind this is that you have a child who is giving you the onset of some symptoms during the early developmental period. Well, that's a theme for the entire lecture, early developmental. But here's the criteria. You have to meet 3 criteria in order to diagnose a child with intellectual developmental disorder, and the deficit has to be in the conceptual, social, and practical domains. So let's talk about the first criteria, A, deficit in intellectual function. Now remember, we're talking about intellectual, not IQ. So very, very important to understand. So do you have a child who has a deficit in reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and so forth. Now remember, everything is age appropriate. So again, you go back to developmental stages. I use Erik Erikson stages a lot, actually, even with adult and geriatric population, to really understand where this client is meeting, and has this person met those Erikson stages, or any type of a milestone that you expect in that population, in that culture, in that setting. All right, and make sure we confirm these assessments with some kind of a standardized tool. Second criteria is deficit in adaptive functioning. Now again, we compare this individual, the child that is sitting in your office, with another child with the same age, gender, socioculture, and so forth. So how is your client doing in comparison with a peer, if you will? Okay, so the idea is your child, the client that is sitting in front of you, does he or she able to live independently in a society across multiple environments such as home, school, work, without any ongoing support, without any adaptive is your client showing adaptive deficit that will limit functioning in one or more of the activities of daily life? And we talked about this a lot, right? Anything that we do in mental health, we always ask this question: what is the impact of this presentation or this symptom on someone's ADLs? This is all about activity of living, daily living. And then the third criteria is the onset. It has to be during the developmental period. I think this is very, very important. For example, let's say you have a 12-year-old male who presented with all of a sudden some kind of a deficit in adapting functioning, unable to maintain ADLs, or perhaps all of a sudden issues in academia or abstract thinking, but previously that child had mastered that stage. Now that cannot be intellectual developmental disorder, because if the child has successfully mastered that step, that stage, then look for something else. It could be some kind of a trauma, maybe abuse, either domestic abuse or whatever the case is. You know, if all of a sudden a child is either disoriented, not making sense, look for other. First of all, always rule out physiological causes, right? We do that for every mental illness anyways. Their basic workup, CBC, are they anemic, infection, and so forth. All right, and just like everything else we do, we always ask for to specify the severity of the disorder. Is it a mild, moderate, severe, or profound? And please remember, this is just a keynote, that we have removed the term mental retardation due to a stigma that was attached to it. It has been changed to intellectual disability. So never ever document. I still see once in a while from outpatient providers documenting either mental retardation or developmentally delayed. Make sure you really use correct ICD code, and the term we really should be using is intellectual developmental disorder or disability. All right. Now, DSM also talk about a global developmental delay, and again, this is a part of a developmental disorder, intellectual developmental disorder, but this is to specify that you have a child who is under the age of 5. So you give this diagnosis somebody who is under the age of 5, who's giving you all of the presentation. The child has symptoms um, of intellectual developmental disorder, if you will. However, that child is not able to undergo any assessment at this time. Maybe because of age, whatever the case is, you really can't use any standardized test yet. However, parent is giving you enough information. They're worried. You're also worried because there are some red flags. So at this time, you're going to document this with the understanding that you will do reassessment next time when the child is able to go through a proper assessment. So pretty much you're going to red flag this case and then revisit that. Okay, now unspecified F79 is used when you have a child over the age of 5 and that child is giving you all of the presentation that would normally meet the criteria for intellectual developmental disorder. However, at this time, child is not able to give you the assessment because of either some physical impairment. Maybe child is either blind or prelingual deafness or some kind of locomotor disability. Any reason where you cannot assess a child at this time, then you will use the term unspecified because you are not able to really specify anything. With the understanding that again you will go back and do the assessment over the age of 5, under the age of 5. That is the criteria here. Anytime you have emergency, you need help, you're still working with the diagnosis, you can use unspecified with the understanding that you will go back and give them proper diagnosis. All right. Second stop is communication disorder. Now, with the communication disorder, you have maybe subcategories, if you will, and they kind of sort of are connected. The first one I have on the list is language disorder. Do you have a child with a difficulty with either spoken, written, or sign language that is below the individual age? Again, everything is age appropriate. So it's how well that child can speak overall language. All right. Second is speech. Now, speech often coexist with a language disorder. And you may have a child who's struggling with both language and speech. With the speech, it's really about the pronunciation of those words. Now, childhood onset fluency is the third subcategory. Do you have a child who stutter or use broken words or take long pauses throughout the sentence? Those pauses are either unnecessary, inappropriate, or very long. Often a child is not able to finish the sentence without using the words such as throughout the sentence and looking for that word, if you will. All right. Now, next is a social communication disorder or a pragmatic disorder. Now, by the age of maybe 4 or 5 years, most children should have adequate speech and language ability. If the child is not giving you that that milestone, if you will, then you have a discussion with a parent or caregiver about social communication. A child come across as socially awkward, if you will. Maybe there's a mismatch with the verbal and non-verbal communication. They're not able to understand metaphor or not understand sarcasm, humor. For example, if you're talking to a child and then you use the word it's a piece of cake or it's just a walk in the garden, they don't understand what do you mean by piece of cake. They will be looking for cake and so forth. Now, this is also a differential diagnosis for ASD, and we'll talk about that in a few minutes. Every time you have a client or a parent or caregiver giving you some presentation, we should always keep differentials in mind, because that then, and you further investigate and you either rule out or rule in those differentials that you were working with. All right, so this is a social pragmatic disorder is actually a good differential for ASD. And then when you have not enough information, you really can't specify, then you will use unspecified communication disorder. There's a clearly some communication disorder, but you really can't specify. All right, so the third type of neurodevelopmental disorder, and then I do want to spend a little bit more time on this one, is ASD, Autism Spectrum Disorder. Um, um, those days are gone when we used to talk about this in two different categories: Asperger's syndrome and autistic disorder. We have combined those two presentation on a spectrum, because we really believe that it's a range of the symptoms, let's say from 0 to 10. So it's a plus and a minus of some symptoms. Those symptoms in previous classification with Asperger's syndrome and so forth, there were several symptoms that would overlap. So therefore there was a need to put this on a spectrum. And I personally really like that. I believe when we had two separate classification, some children who were very high functioning were not meeting the criteria, and they really did not get the proper diagnosis, and therefore they did not receive the treatment. And those children truly needed the treatment, or they not, well, yes, everybody needs the treatment, but those children would have received the maximum benefit from that treatment. So I'm really glad that with the new DSM, it's a part of the spectrum now, so that we can really offer help to these children. Okay, what is the etiology? Honestly, we really don't know. Again, we truly believe that there is high level of a genetic component attached to it. It tends to run in the family. So the concept with ASD is you have two things going on. You have a lack of interest in social interaction, a very complex neurobiological and developmental disability, and it appears, the presentation will appear in the first 3 years of life. So therefore we are talking about a neurodevelopmental disorder lecture today. Children with ASD remain emotionally detached from others. Again, this is a spectrum, right? So you will see some children very high functioning than the others. But these are just a general presentation of common symptoms where a parent will say that a child is not making eye contact, or they resist touch. Sometimes if parents, they have multiple children, they will describe this child as being very unique or unusual. They'll say my other three kids, they were not like that. They will describe this child as uncuddly, unresponsive, or unusual baby. And there's a delayed in language skills, both verbal and nonverbal communication. All right, so I think we talked about this earlier. Two conditions, autism disorder and Asperger's syndrome, were previously diagnosed as a separate, but now they are on a spectrum, so that's a good thing. DSM-5 and even the new version 5TR does indicate two different types. Social communication, which is the language, and social interaction, which is the intellectual impairment. So always keep those two things in mind: language and intellectual impairment. So in other words, communication and social interaction. All right, children with ASD may or may not have intellectual disability, but they commonly show uneven pattern of intellectual strength and weakness. Hence, it's on a spectrum. All right. So here is the criteria for ASD. So criterion A says it's a persistent deficit in social communication and social interaction across a multiple contexts as manifested by all of the following. So in the first criterion, you have three, and you have to follow all, you have to meet all three. All right, so A1 is deficit in a social emotional reciprocity. For example, you have a child who has symptoms, failure of a back and forth communication. Now, a child at a very early age um, is able to have a back and forth conversation. I'll give you one example. Let's say that you are driving downtown and you stopped at a red light, and there's a train, that a child who's sitting in the back seat, he sees that train or ambulance, or something very colorful, right? Now, at that time, a child is going to have a conversation with you. At a very early age, child has learned one thing, that their brain is different than your brain, and what they see, you may not be able to see that. In order for you as a parent or a family member to experience what they are looking at, they have to bring that to your attention. So they will say, Dada, Mama, Grandpa, look outside, look at the train, look at the ambulance. So they are talking to you, but if the child sitting in the back seat is not talking to you about that a train, ambulance, or a fire truck, or whatever the case is, as a matter of fact, they're not even making eye contact, they're not interested, they're meeting the criteria here, at least one criterion. Okay. Second is a deficit in non-verbal communication. So again, not able to have facial expressions, or not able to make eye contact, or body language deficit is there. The third one is a deficit in developing, maintaining, and understanding a relationship. Now, that can go in various social contexts. Inability to make friends, or difficulty in sharing and toys and so forth, or absence of interest in peers. Usually, a child would look forward to see his friend, or when cousins come over, or they play with siblings. But if this child is not showing any interest, that would be a red flag. So this is criterion A. You have to meet all three. Criterion B is you have a restricted repetitive pattern of a behavior and interest, and you have to have two of the following. There are four categories, and you need two out of those four. So B1 is stereotyped or repetitive motor movement, use of object or speech. So here you're going to have a child who's lining up all the toys, or flipping all the objects and so forth. So B2 would be where you have a child who need to take same routine. Everything has to be same. This is very, very rigid thinking pattern. Greeting rituals are the same. Need to take a same route to school, maybe, or to the park. You can't change that route. That gives them anxiety. They feel the need to eat same food every day. Very rigid. They will maybe wear a same outfit. If you make any changes, that increase some anxiety. All right, and number three is or B3 I should say, is strong attachment to unusual objects. Okay, so again, they're fixated, interest that is abnormal in intensity or focus. So one example I want to give you here is hopefully you have watched that comedy show Big Bang Theory, where Sheldon he was giving us the symptoms or the presentation of the ASD criteria. Remember a high level of OCD where he has to sit at a certain side of that couch. Nobody can sit on his seat, and anytime he would go to his friend Penny's house, he would have to knock at the door 3 times. Routine as far as what he needs to eat on certain days, and TV shows, and his obsession with certain objects and so forth. So very, very clear presentation of ASD. All right, number 4 is either hypo or hyper sensory input or unusual interest in sensory aspect of the environment. What do I mean by that? Well, these individuals are going to have adverse response to specific sound or smell or excessive touching of object. So either lights or any type of a movement, or adverse response to sound and texture and so forth. So again, you need to meet 2 out of these 4 criteria. All right, and then criterion C is that these symptoms must be present in early developmental period, but may not become fully manifest until social demand exceed. We talked about that. So in other words, the symptoms has to be present in early developmental, however, they may not have impact on that individual later on in life, and that's fine, that's acceptable. Another criterion is that symptoms cause clinical significant impairment in social, occupational, or other impairment. In other words, have impact on the ADLs. These are very common criterion for anything, for any type of mental illness, to be honest with you. And of course, we want to rule out other differential diagnosis, make sure these symptoms are not explained by something else, such as intellectual developmental. That's the first one we did. Are they really meeting the ASD criteria, or is it a case of intellectual disability, or is it a global developmental delay? Especially if the child is under age 5, which most of these children are. Remember, the onset for ASD is by age 3 or so, right? So perhaps at this time, global developmental delay is the right answer, and then bring them back and see what's going on. With the understanding, and I like that about DSM, that we understand that these symptoms frequently co-occur with other diagnoses. So now we are really understanding the combination of ASD and ADHD. So make sure we understand our differentials very well. Here's a quick note that if you have a child who was meeting the criteria of DSM-4 or any other previous DSM versions of either autistic disorder or Asperger disorder, those children should be given a diagnosis of ASD now. All right, and when you have a child who has a marked deficit in social communication, but whose symptoms do not otherwise meet the criteria for ASD, that child should be evaluated for social pragmatic communication disorder. And that's what I was telling you earlier, that differentials are so important. When you have a child with just a social communication, do not just give them the diagnosis of ASD, think about social pragmatic communication disorder. Is that a good a diagnosis for this child at this time? And if the answer is yes, then evaluate for that diagnosis. It's always a good idea to give or come up with a correct diagnosis and a correct treatment plan. And of course, specify if the severity of that criteria based on the social communication impairment and restricted and repetitive pattern behavior. So always document the presentation. All right, okay. And specify if ASD is with or without any intellectual impairment. Now we are really talking about severity and specification. Is it with or without a language impairment, so that they can get appropriate treatment. And then any associated genetic component that you are aware of that needs to be documented. All right, okay. And also document if the client has a catatonia or not. All right, so let's talk about management real quick. I think the overall goal is to target core behavior to improve social interaction or communication and long-term skills in independent living. That would be a good overall goal of these clients. And we should always have, once we diagnose somebody and we are coming up with a treatment plan, we should always involve the child and the caregiver to develop a clear target goal, what exactly we're trying to achieve. So as I said, maybe the goal is to improve social communication, social interaction. So the first thing that we has to establish is trust with that child. Remember, again, going back to the Erikson developmental stages, trust versus mistrust. That's the first stage that that child must master. And these children, they need a lot of help with that. So provide a consistent caregiver. If you are the clinician, make sure you see that child consistently and do not change clinicians on them, especially if they're hospitalized. We should really have or at least make attempt to have a consistent charge nurse or caregivers in the hospital setting to maintain that trust. And always reassure the parents that there isn't anything that they did wrong. I think we have to really educate the caregivers as well. And ABA, applied behavior analysis, is the treatment approach. There's no one standardized a treatment plan. It's highly individualized based on the need of the patient. I think the best thing that we can do as a clinician is early identification, at least to bring them into the system, alert that chart and notify the school and the caregiver and counseling and so forth. So early interventions are very, very important. I believe in CBT. We know that CBT has a significant evidence for depression and anxiety and so forth, but there are some evidence for efficacy of CBT in ASD as well. Now, from a medical standpoint of view, for us as a clinician, for psychotherapy, pharmacology, I should say, we can offer antipsychotic drugs, risperidone and aripiprazole. That these are second generation antipsychotic medication. They are approved for ASD patients over the age 5 to 16, and we prescribe these drugs to really manage the symptoms. This is very important to tell the parent there's no treatment for ASD. These medications are not going to treat, but we are going to focus symptoms such as maybe irritability. The child is very irritable, tantrums, aggression. Those are the symptoms that we are going to treat with these second generation. Sometimes I actually have seen first generation Haldol as well. All right. And sometimes, oh, there you go. Target symptoms should be, to treat if the child is very irritable, self-injury, aggression, mood swings, and so forth. In SSRI, there's a role for SSRI, antidepressant. Fluoxetine appears to be very beneficial for OCD type of a behavior that is often seen in these children. All right. So next stop under neurodevelopmental disorder, number 4 is attention deficit hyperactivity disorder, or ADHD. I am going to spend a lot of time on this topic because this is very high yield as far as the real life is concerned, and from the exam standpoint of view as well. All right. So there are some core symptoms of ADHD that we will try to master in this lecture. The first one on the slide is inattention. So I'm going to put number 1 here. So you have a client that is sitting in your office, and one of your differential is ADHD, and that's where the story begins. And you're going to ask some questions. Most of the time, the client comes to you either by school recommendation, or perhaps a child is a child lives in a foster care and is accompanied by a caregiver or a parent or a grandma, or so child is not going to be alone most of the time. You have a way of asking these questions and get a good history to really develop your ADHD case, if you will. Okay. So the first question is, the presentation is a rapid shift in attention from a topic to topic. Now this is a mind is jumping from one topic to another. Child is not physically moving from one place. So child is not physically moving from one place to another, but child has a difficulty keeping concentration on one idea. That would be inattention, and that is the second most common type. In a few minutes I'll tell you what's the first most common type, but number 1 is the second most. All right. Hyperactivity is the second core symptom, so I'm going to put that over here. So hyperactivity is when the child has difficulty to remain in one place for age appropriate. That is very, very important. For adult, if it's adult audience, adult students, I expect them to sit through my 2-hour, 3-hour lecture with a few breaks or so. But if I'm talking about a child, 7-year-old, 8-year-old, I do not expect that child to sit through my lectures more than, I don't know, 25 minutes or so. So again, everything is age appropriate, right? So under hyperactivity, you have a client who's moving out of their seat. They appear to be socially immature, and they are often in trouble, if you will. Teacher will explain, or teacher will describe that child as being rude or difficult, if you will, right? They're always in trouble, if you will. Okay, so this is the third most common type of a symptom, but very common in preschoolers. In preschooler, hyperactivity is very, very common, and rightfully so. That's the age, right? All right. Number 3 here is impulsiveness. So I'm going to put number 3 here. So now, impulsive behavior, prone to risk-taking behavior, fail to consider consequences of their action. I always ask this question: why do children act as if they're missing a part of their brain? Well, the answer is because they are, right? Remember, the prefrontal cortex does not really fully develop until late early 20s or so. So you're talking to a teenager, and they're taking these behaviors, risk-taking behaviors without any consequences. And up to some degree that's acceptable. That's a normal phenomena in during the teenage or adolescent. But now they are doing this up to a degree where they're putting themselves at risk, great risk for injury, perhaps unintentional poisoning or inattentive driving. It's impacting their mood as well. They are at risk of either suicidal ideations and either harming themselves or someone else. Their mood is changing. um, so that would be impulsive behavior. And number 4 is combined. So combined means they have multiple core symptoms. So combined is the most common, and that's but I didn't want to put combined as a number 1 here because I wanted to set the stage. So now you know that the most common type of ADHD is really a combination of 1, 2, and 3. And DSM really talk about these symptoms, core symptoms, as specifiers. We are supposed to specify what is predominant. Is it a combination, or is it just inattention, or is it predominantly just hyperactivity or impulsiveness? So take a look at it. This is very, very important slide. All right, etiology. We believe, I think I mentioned very briefly in the previous slide about a prefrontal cortex. So we believe that there's inefficient tuning of prefrontal cortex. We believe in two neurotransmitter hypotheses, and that is a dysfunction of a dopamine and dysfunction of a norepinephrine. Now recall that the function of a dopamine is to give you reward and pleasure and motivation. And if that is decreased, if the levels of dopamine is decreased, you are not going to have any motivation, or you will have a decreased motivation. Now, norepinephrine helps with attention and arousal. Remember, these are the key players for sympathetic nervous system. So sympathetic nervous system is under the drive of epinephrine, norepinephrine, and dopamine, and so forth. That's where the blood pressure goes high, pulse rate, respiratory rate, because you are fighting here, right? It's a fight or flight type of drive, right? So that makes sense. So when the levels are low, or if there's a dysfunction, then you are not able to maintain that focus or attention, if you will. And we'll talk about sympathetic in few minutes when we talk about medical management or pharmacological interventions. All right. There's also some degree of a genetics attached to ADHD, tends to run in the family. And of course, there's an environmental risk factor. Low socioeconomic status appears to be it shows up when we study etiology. Foster care. I remember when we talk about a client in a special population, a client who are very vulnerable, foster care, homelessness population. That's an environmental factor. Or maybe you have a child whose parents had some kind of a mental disorder, either one parent or both parents. Maybe child had a low birth weight, or maybe after birth, the child had some kind of a traumatic brain injury, or maybe child was premature. Those are all the risk factors. Now, originally, ADHD was thought to be only a childhood disorder. However, now we know that this tends to run across the lifespan. And I think I mentioned earlier that I manage inpatient adult psychiatry unit, and I see a lot of clients with adults with ADHD. ADHD tends to decline with age. You're not going to see that much in geriatric population, so that's good news. and parents pass this disorder. We talked about genetic. All right. In order to diagnose a child with ADHD, symptoms must be present in at least 2 settings. And that's a good, right? That's so that way we are not really jumping the gun if it's just one setting. So either at home, school, or work, or some kind of social environment, and must occur before the age 12. So remember that part, at least 2 settings and before age 12. Now, they don't have to be diagnosed before age 12. The symptom has to be present before that, right? And if it's a one setting, then something is wrong with the setting. If the child is only in trouble at school but behaves very well in school at home, then school is a problem. Or the child is in trouble at home and overall doing very good job in school, teachers have no problem, grades are good, so then your differential would be some kind of environmental issues at home, either domestic violence, abuse, whatever the case is, that requires a different type of approach that shouldn't be ADHD. All right, so let's talk about the criteria now. According to DSM, criterion A is persistent pattern of inattention or hyperactivity, impulsive. We talked about that. That will interfere with functioning or developmental. And you have one or two here. Let's talk about these in detail, actually. Number one is inattention. Now, with A1, which is inattention, you have 9 criteria, and you have to have at least 6, minimum 6 or more out of those 9. And symptoms, they must be present for at least 6 months. Um, the, the way I remember this, honestly, is you have a child, so remember the 12-year age, the symptoms must be present before age 12, and then so that's a 12, and then you have to have a 6 of these symptoms, and the time frame has to be at least 6 months, so 12, 6, 6. Okay, um, so what are the symptoms? Well, okay, we'll talk about symptoms in a minute, but let's talk about this little disclaimer here. When you have a child who is 12, the symptoms have to be 6 or more, but if the child is 17 or older, then you only need 5 symptoms. So just remember that exception to the rules. All right, so here are the 9 symptoms, and you need 6. Um, the first one is the child often fail close attention to detail or make a careless mistakes. Remember, these are not intentional mistakes. They're not trying to harm somebody. This is a careless mistake. They forgot to do it. They didn't mean to. And these are just like they overlook or miss detail. Maybe a child did his homework or exam, but failed to put a name on it or something like that. Um, the second criteria is often has a difficulty sustaining attention, or they are not able to remain focused during lectures and conversation, and especially if something is they're not interested, so they're not going to do any lengthy reading or so forth. Option C, a child often does not seem to listen when spoken to directly. Mind seems somewhere else. They're absent, not physically, but mentally they're absent. And D is often do not follow through instructions or fail to finish their schoolwork or homework and start. They start task but quickly lose focus, easily sidetracked. Okay, they have difficulty organizing their task, cannot prioritize, cannot organize, very messy, disorganized, poor time management, not able to meet deadlines. So when the parent are giving you or school is giving you these symptoms, check them off. It's very easy to follow this. Remember, they need 6 out of these 9 criteria. Um, Then next one is often avoid, dislike, or they're reluctant to engage in tasks that require sustained mental effort, usually schoolwork, homework, and so forth, or completing any form. Give them a DMV form and see if they can fill that out. Often lose things necessary for tasks or activities. For example, items missing, pencil, where's your backpack, where's your paperwork, and so forth. All right, easily distracted by external stimuli, and often forgetful in daily activities. Okay. All right. Now the second part, that was number one. Number two is a hyperactivity and impulsivity. Now again, you need a 6 out of the 9, and again, at least for 6 months in 2 settings. So the same rule apply, and same thing if it's age 17, you need just 5. So the first one is often fidget with or taps hand or feet, can stand still, leave their seat in situation when they were expected to be seated, and so forth, especially in the classroom, workplace. Often run about or climb in situation where it's inappropriate. Um, Often unable to play or engage in leisure activities quietly. That's the key word here. They're always on the go, act as if driven by a motor. Everything is slow for them. They think you guys are so slow. Often talk a lot, excessively talking, jumping from one topic to another. Again, remember, we have to always keep an eye on the differentials. Is it ADHD or is it early onset of either bipolar, mood disorders, schizophrenia, depending on the age, especially if you have like a 13-year-old in front of you, what exactly are we dealing with? So criteria is very, very important. All right, so take a look at all the criteria here. Are they meeting ADHD, or move on to your next differential diagnosis? Often has a difficulty waiting there for their turn. They're gonna jump in. They interrupt. Um, Again, not waiting for their turn, or they may introduce into or take over what others are doing. All right, and here's the disclaimer that you have these symptoms. They were not present, or they were present, I should say, prior to the age 12. So if you have a child who's a 17-year-old, make sure the symptoms are present before age 12. It's okay to diagnose them later on, but the symptoms have to be present before. All right. And again, it has to be setting in 2 different settings: home, school, work. We talked about that. Um, there's a clear evidence that the symptoms interfere with or reduce quality of life. So we talked about the ADLs. These are very common criteria for most of the mental illness. And of course, you want to rule out some other diagnoses: schizophrenia, psychotic disorder, bipolar, mood disorders, anxiety, and so forth. Or is it a substance use, or maybe substance withdrawal, or personality disorders? We'll talk about these later on. Okay, and specify, this is what I was telling you with my first slide, um, that you have to specify if it's a combined, which is most common. ICD code is F90.2, and so with that, you're meeting both criteria A1, which was inattention, and criterion A2, which is hyperactivity and impulsivity. So both of them are meeting over the past 6 months. There you go. You have the diagnosis of combined presentation of ADHD. If it's a predominantly A1 criteria, then it will be inattentive presentation. That's F90.0. And if you're only meeting criterion A2, but not the A1, then that would be predominantly hyperactive impulsive presentation. All right. And of course, specify if it's in a partial remission and so forth. I'm going to have you take a look at this. Specify if it's a mild, moderate, severe. Differentials, again, I think we already talked about that. Always keep a few differentials in mind. Is it anxiety that is presenting this way? Is it depression? Is it insomnia? Remember, these three are so important to rule out, and these are very common diagnoses, and the symptoms do overlap. For example, I don't feel good, or I can't sleep, or I don't want to eat. That could be anxiety, depression, or insomnia. So very, very important to do a proper assessment. Give them a PHQ-9 or Hamilton anxiety scale and so forth, and see exactly what we are dealing with. Is there sleep apnea? Is there why their mood is very irritable, or they can't focus, or they're sleepy throughout the day and not following instructions? What exactly is it? We always want to rule out other things, right? Conduct disorder, we'll talk about this in detail in future, in few weeks or so. Is it a learning disorder? Is it a hyperthyroidism? So always do basic workup. Lead toxicity or some environmental factors. All right, so the treatment approach is multimodal treatment approach, MTA. We always start with a non-pharmacological intervention, just like anything else in physical medicine or any other medicine approach, is to talk about non-pharmacological interventions. At least consider those, right? So this is your individualized educational plan, IEP, offer positive reinforcement for appropriate home and school behavior. Parent education is a big one. We really need to, especially if you're going to start with like a medication, you'd really need to educate, of course, the child, but the caregiver as well. And parent education is important to give them some tips how to manage that behavior. All right, pharmacological interventions, that's where I want to spend a lot of time, because that's what you will be doing most of the time. Pharmacological interventions consist of either stimulant drug, methylphenidate class or amphetamine class. Then you have a non-stimulant, and I'm going to talk about these in detail, but please understand that pharmacological interventions are highly individualized. There's no one answer. There's so many options to pick from, and that's a good thing, but it can also be very confusing. Rule of thumb is, if you are going to start pharmacological interventions, have a good conversation, of course, with the patient and with the caregiver. Make sure you give them the options and come up with a plan. But the rule of thumb is, we start with a stimulant. That is the first line of treatment, unless there are good compelling reason for you not to start stimulant, and we'll talk about that in a minute. All right. What are the prereqs for starting somebody on psychopharmacotherapy? Let's say that you have a 13-year-old male sitting in your office along with his parent or caregiver, and they gave you enough symptoms and you have successfully diagnosed that child with ADHD, and then now you're talking about a therapy approach, psychotherapy, pharmacological interventions, and you have decided to start stimulant preparation, which is the first line treatment anyways. So before you really write that prescription, you should do a very complete, comprehensive cardiovascular exam, get a very good family history. What you're trying to do is you're trying to find out if this is even a good candidate for a stimulant drug. The reason we are worried about cardiovascular history is because of the mechanism of action for these stimulant drugs. All of the drugs pretty much works the same. We'll talk about that in a second, but let's talk about the mechanism of action. Once you understand this, it's very easy to talk about side effects of these drugs. Okay, so a quick recap. We already talked about this, that it is the decreased level of dopamine and norepinephrine that are responsible for ADHD, right? So we talked about that. It's a decreased level that will give us of these levels that give us a decrease motivation. These are the core symptoms of ADHD. You have a decreased motivation, decreased alertness, a child is not alert, decreased attention, also decrease learning, and decrease memory, right? So you're trying to manage these symptoms, trying to reverse these. You want to increase motivation, you want to increase alertness, and so forth. How do you do that? Well, we can increase the level of dopamine and norepinephrine. One way of doing that is by giving stimulant drug. So if you have, let me draw a presynaptic cell here. This is a presynaptic cell, and this is a postsynaptic cell, and the space between pre and post is called synaptic cleft, right? So presynaptic cell, these are neurons, right? They have multiple vesicles in them. These vesicles have a lot of neurotransmitters like acetylcholine, serotonin, but the two that we are interested right now are either dopamine or norepinephrine. So let's say dopamine is released in the synaptic cleft here, and we know that these cells have receptors. The postsynaptic cell is going to have receptors specific to the neurotransmitter that is present in the synaptic cleft. For example, if this is a dopamine, dopamine can only bind at dopamine receptors and will not bind at, let's say, acetylcholine receptor, right? And receptors for dopamine are also specific. You have a D1, D2, D3, D4, D5, and for acetylcholine you have either a muscarinic receptor or nicotinic receptors. But the point here is they're very, very specific. So once the activity of a dopamine is over, two things will happen to these neurotransmitter, or to any neurotransmitter. The first one is they will be destroyed by enzymes, and these enzymes are also very specific. Enzyme that will destroy dopamine cannot destroy acetylcholine. So these are enzymes that are specific. So anyways, we call that activity as a degradation. So these neurotransmitters will be degradation of the neurotransmitters. Second thing that can happen to these neurotransmitters is they will actually go back to the presynaptic cell, neuron cell, so that we can reuse that later on. That's a good thing. We don't want to waste these. We call that a reuptake. So reuptake of neurotransmitter so that we can use that later is a good thing. However, the problem today is that you have a child who has a low level of dopamine to begin with, and somehow we want to increase the concentration here. So the one way of doing that is if you prevent the reuptake of these neurotransmitters. So we call that reuptake inhibitors. And by inhibiting either dopamine or norepinephrine reuptake, you increase the level of dopamine in synaptic cleft, and sometimes that's all you need to actually manage the symptoms, and that's what is happening with these patients. Now, The problem is when you increase norepinephrine or dopamine levels, you are actually increasing the impact of a sympathetic nervous system. So remember there are two types of nervous systems, sympathetic and parasympathetic. Sympathetic is a flight or fight. So during sympathetic, that's where you see increased heart rate, increased blood pressure, and also increased respiratory rate. The blood is actually decreased in the GI tract, so decrease the GI. In other words, this is not the time to waste our blood and energy to digest food, right? So we need to run, we need to make critical decisions, high thinking, critical thinking, so we need a lot of blood. So you're going to have a bronchodilation, increase the respiratory rate, and so forth. Now, this is important. This concept is important because this will cause a side effect. Well, I'll talk about that in a minute. But let me erase all that, please. So when you have a client that you're going to start somebody on stimulant, make sure that we have a baseline of their vital signs and baseline of their eating habits, their weight, their height, BMI, the whole 9 yards, because these drugs are going to impact their appetite and the heart rate and so forth. If you don't have the baseline, you wouldn't know if they were already high or abnormal, then you wouldn't know if the drugs were causing it or not. Okay, so so get the child baseline height, weight, and so forth. Screen for other risk factors such as a bipolar. That's a prereq. Make sure we are not. It will be very bad to treat someone with ADHD medication when the diagnosis was bipolar. That'll be a bad thing to do, right? Or make sure they don't have a history of other stimulant medication they're taking. That will be that will not be a good thing. If they have that behavior where they are actually using other stimulant, you don't want to give them a lot of stimulant further. Okay, and then make sure we rule out if they have any appetite problems, any sleep issues, and so forth. So once you have we talked about that. Okay. Those with the signs and symptoms of a substance use should undergo evaluation and treatment of addiction before we treat ADHD if possible. So the priority at that time should be to treat the substance use instead of adding ADHD medication. And more specifically, we should not be adding a stimulant at that time. Now, here's a nice concept. I want to talk about this briefly. Adults with ADHD, they smoke as frequently as adults with schizophrenia, about twice the rate of normal adult population. The reason behind that is the fact that nicotine subjectively improves ADHD symptoms. Now, this is interesting because since I do a lot of adult psychiatry, so at least in my setting, I have inpatient client and their primary diagnosis is really either bipolar or schizophrenia, schizoaffective disorder. So my treatment focus is, and rightfully so, is really to decrease the symptoms of psychosis, agitation, hallucination and delusions and so forth, right? Now, but these individuals also have ADHD, and I don't know why, but for some odd reason, clinicians tend not to treat ADHD with adult population, especially if they have some other mental illness. There's a trend to treat other diagnoses or comorbidities instead of treating ADHD. My recommendation to you is when you have a client with the multiple comorbidities and they also have ADHD, we should treat ADHD, because if we don't, they are going to actually use some other substances such as nicotine or something else to improve their symptoms. We should be actually focusing on that as well, because we are supposed to help them and treat, you know, if not all of their symptoms, but at least to pick a few that are important. So what I do is, of course, it requires a very good history taking, but the one question I ask is, do you still crave? At that time when they are with me in psych facilities, it's a controlled environment, they cannot smoke, but they're still craving. The minute I discharge them, they are going to start smoking again. So I assess for ADHD symptoms, and I offer treatment, and I also offer nicotine patch or something else. So please keep that in mind. I think it's a very, very important concept. All right, so let's talk about the treatment now. You have decided a treatment approach. There are a lot of options. The rule of thumb is, if possible, we start with a stimulant drug. These are preferred over non-stimulant because of a long record of safety and efficacy. Now, the current guidelines are that we should actually start with the stimulant, and more specifically once a day, maybe sustained release or long acting, I should say. And the reason behind that is that that's more convenient and does not give you a lot of rebound side effects. Okay. So I think I made that point very clearly, that stimulants and medications are preferred over non-stimulant. At least they are a first-line treatment if patient is able to tolerate. All right. The example under stimulant preparations are methylphenidate, and I think these names are very familiar to you, Ritalin, Concerta, and so forth. One side note I want to talk about Detrena is the patch. Now that's a good thing, because you may have a child who's not able to either swallow the medication, and they need a stimulant. So the best approach for that child may be either liquid, if they're able to drink, or the patch. Now the beauty about the patch is a transdermal patch that you can apply on the skin, and it's approved for children and for adolescents by FDA. Now the advantage of the patch is that you don't have to swallow those pills, and patch can be removed if the child does not need the medication. Let's say the child has already done his homework, in the evening, child just want to rest or go to bed, but if the patient was on, let's say, Concerta, the medication still is going to be in the system if it was a PO, because that comes in a PO. But the child can actually remove the patch in the evening so that the child can go to bed, because remember, one of the side effects is insomnia. So think of sympathetic nervous system drive. When you are on the run, sympathetic drive will not let you go to bed, right? Because that is the role of a parasympathetic nervous system. Remember, parasympathetic is rest and digest. So that's one beauty about the patch, that you can actually remove, so you can individualize that medication. If the child is not able to tolerate stimulant, then of course you have some other options as well. Okay, so under stimulant, the second part is dexmethylphenidate, Focalin. I'm sure you have heard this name. One is not necessarily superior than the other, to be honest with you. You have a lot of options, and it requires a lot of conversation with the child and with the caregiver to really select either short-acting medication or long-acting. The beauty about short-acting, such as Ritalin, would be that it will help in especially in the evening when the child has done the homework and so forth. This medication will wear off after, I don't know, 3 to 4 hours or so, right? So then patient will be able to sleep. But that means that this child will need multiple medication throughout the day though. So that's a bad thing, right? So there's the pros and cons. But the Concerta is like a long acting, so then you don't have to take medication throughout the day, but then you're dealing with the insomnia or maybe poor appetite for dinner and so forth. So again, it's a conversation that you have to have. Another interesting point about these drugs is honestly is that if one patient tells you that, oh my gosh, I really like a Focalin or Vyvanse, which is a lisdexamfetamine, and the other child may tell you, oh, I cannot stand Vyvanse, give me Focalin, or vice versa. Highly individualized, and that's a beauty about these treatments. Okay, and dextroamphetamine is another option. These are all a stimulant. Now, another big category under stimulant is really amphetamine salt. Or mixture of amphetamine salt, and then the brand name that we are familiar is Adderall. Both of these drugs, like a methylphenidate or Adderall, they work very well. This is really the first line treatment. They both block the reuptake of norepinephrine. Adderall is really not a first line. We start off with Ritalin and so forth, but again, if the patient is not able to tolerate, you can change. Okay, we will talk about these side effects in a minute, but let's talk about the non-stimulant real quick. Now, you have few options. The most, I guess, the big one under non-stimulant is tamoxifen, which is Strattera. Comes as a 10 to 100 milligram per day. Now, this is a selective norepinephrine reuptake. So it's not, remember there were two issues, the dopamine and norepinephrine. This is a selective, and that because it is a selective, it's a little bit neater, you can say. It's very similar to it is antidepressant. So it's not a controlled drugs. Remember, the stimulant drugs are Schedule 2 drugs that are controlled, very addictive. This one is not. These are sometimes tolerated better than stimulant. However, this is not the first line though. The better tolerated, but the efficacy for stimulant is better than the non-stimulant. Another disadvantage of a non-stimulant is that you cannot really use this as needed. You have to take this for a long time to stay in the blood serum, if you will. The level has to be there, just like antidepressant. But the stimulant drug, you can skip. They can be used as needed, if you will. And another big issue with Strattera is there's a black box warning for risk of suicidality in children, especially during the first month. So that requires a lot of patient teaching. Be very careful. Make sure you document that. Okay, another category under non-stimulant is your alpha-2 alpha-2A adrenergic receptors. And then the examples are, the two good examples are your guanfacine and clonidine. Now, the difference between clonidine and guanfacine is that if you have, I'm going to draw this diagram here real quick. If this is the, let's say I'm going to put guanfacine here, this drug will target alpha-2A receptor. Now, alpha-2 receptors are present throughout the central nervous system, but these receptors are the mediators of the effect of norepinephrine. So in other words, they're going to increase the norepinephrine, and more specifically in prefrontal cortex. And that's where you will regulate the symptoms of hyperactivity, inattention, and impulsiveness, and so forth. And that's a good thing. That's what you want. So that tells you that guanfacine is actually very selective. It's a relatively selective than clonidine. Clonidine, um, I'm going to actually just maybe do that and put C here. Now, clonidine, of course, you have alpha-2A receptors that will help, but clonidine also have impact on alpha-2B receptors and alpha-2C receptors. Now, when you bind at alpha-2A receptors and helps to increase norepinephrine, that will give you a therapeutic effect, and that's a good thing. That's what you want. But alpha-2B and C will actually give you the side effect from clonidine. And alpha-2 receptors in high concentration, and especially in the thalamus, will actually give you the side effect of like a hypertension and so forth. Okay, so I'm gonna actually erase all that. Give me 1 second, and we'll talk about the drugs in a second. Okay, so again, guanfacine, I actually use that a lot in adult population. It's not a controlled drug, and it's FDA approved. And the reason I use this is, especially if you have most of my adult patients, they do have a history of substance use, and therefore this is a non-stimulant. I use atomoxetine a lot as well, by the way. So both of these are good examples, and once in a while I do have a few patients on it. I actually prescribed somebody last week clonidine, and I use that um, to calm them down along with everything else that I'm trying to treat. And remember, that was a side effect when clonidine effect on alpha-2B and alpha-2C, and we take advantage of those side effects sometimes of the sedation along with everything else. So if you're using clonidine for that, make sure you start at nighttime. All right, we're almost done. So talking about the side effects now. Now, managing stimulant adverse effect is challenging. Most mild adverse effect may resolve with the time without any interventions, and sometimes you just may have to adjust the dose. Or maybe time of the administration. If it's insomnia, give them early, or they can skip, something like that. Or sometimes you just need to change the formulation, maybe from one stimulant to another stimulant, or maybe perhaps change from stimulant to non-stimulant. But generally speaking, the side effect of stimulant drug, number one I have on the list, the big one, is a decreased appetite. And we should be giving a good patient teaching to our clients regarding that. Okay. So remember, it's going to decrease appetite. So my recommendation is always make sure they eat before they take the medication. So eat. And what do you eat? Well, eat well-balanced and nutrient-dense food. Not junk food and not high-fat food. High-fat food will, if it stays in the stomach, it's going to actually decrease the absorption of the stimulant medication, so you're not going to get a good therapeutic effect. So I always encourage take the medication on empty stomach if possible. So in other words, eat before, an hour before, so that you can take the medication and have a good absorption rate and get a good therapeutic effect out of that. Offer food to the child that they like, especially for the noon meal, which is often affected by the medication if you took the medication in the morning. And most people do, because they need that when they go to school and so forth. Okay. Second is a poor growth. Now, if that, of course, we will be managing their height and weight and BMI and then plot them on the graph. And if this becomes a concern, you may offer drug holiday um, and refer them to dietitian. Um, During the summer break or winter break, or even on the weekends, if they don't need the medication, they should not take the medication, and usually that helps them to catch up. Eventually, most of the individuals are able to catch up with their growth. Number three is dizziness, or even sometimes, blood pressure changes. And we talked about that because of the effect on the norepinephrine and so forth. So we always monitor blood pressure and the heart rate, make sure they're drinking enough fluid. Especially if the symptoms are associated with the peak effect, especially if they're on short-acting medication, then perhaps we can talk about a long-acting preparation, which is really the recommendation anyways, is to start with or to maintain or manage, I should say, manage our symptoms with a long-acting medication. Keep an eye on a sudden cardiac death has been reported, so be very, very careful. Next one is insomnia or nightmares. Make sure we really talk about a good sleep hygiene habits. Recommend to maybe either decrease or just to skip altogether the last dose of the day. They don't need it, especially if they have done their homework and so forth. So if they miss that, that should help with insomnia. Or if they're using a long-acting preparation, maybe change to short-acting at that time, or take the medication early in the day to help with insomnia, or maybe switch to non-stimulant altogether. It's really it's like a playing chess. You really have to be very, very careful. All right. Another side effect is the mood swings, mood changes. So that's number five. So the mood is very labile, especially during the peak concentration of the medication. Try to either decrease the dose or switch to long-acting preparation. Just we talked about that. Um, all right, take a look at it. Another one is a rebound. And now rebound effect has to do with the fact that the symptoms or the adverse effect that occur as the medication is wearing off. A rebound effect may improve by, of course, increasing the dose of the long acting in the morning, or you may add a small dose of a short acting at the end of the day if the medication is wearing off and they don't have symptoms. I personally, this is just me talking, I personally do not like adding more dosages or more medication. I usually increase the dose that the patient already has. I do that for everything else, pretty much for diabetes, hypertension, and psychotropic medications. If situation allows me to do that, if I try to take that to max dose before I add another agent. But you can add a short acting if you want to, or the patient is okay with it. Number seven is tics. Now, it's interesting that these medications do not really cause a tic, but they may unmask tics. Now, if that is the case or it's getting worse, you can actually see if you can take them off of the medication. Um, uh, and see what happens if tic continues when the medication is discontinued. Then that's great, but otherwise improvement of medication or at a low dose may be just coincidental. Uh, you know I that usually requires a reassurance, to be honest with you. All right, another is number eight is suicide. and psychosis. If you have a child who's taking these stimulant medication and they develop a severe psychiatric symptoms, either suicidal thought or hallucination, or maybe agitation, aggression, number one, verify that they're actually taking the appropriate dose. They're not taking too much. They're taking the way you prescribed. If that is the case, if they are taking the medication the way you wanted them to take, then decrease the dose, right? Or maybe perhaps you can discontinue altogether. Um, Always remember that stimulant medication can be discontinued anytime. You don't have to taper them off. You don't have to taper them off. Okay. And number 9 is very important. I spent some time with this. I think it is our responsibility to really have a honest, open communication with our clients and talk about a divergence and misuse. And I do that even with the pain medication, with adults and geriatric population as well. That I'm giving you this prescription and I can refill, but please do not misuse. If there's any evidence of misuse, then you should have an open discussion. And the reason we should do that so that these children or students or adult, anybody, they're prepared if they are approached by someone else to either share their medication or sell. They need to know what is the answer, so teach them that this is my medication. Talk to your doctor. I cannot share. These are not M&Ms. So it's very, very important. It works very well for me when you do patient teaching. Seems like the client understand that I am on their side instead of blaming somebody and playing that catch-up game. Okay, this slide is very important. We're almost done, guys. This slide is very important. Anytime we treat a patient, we should always have a clear goal. What exactly are we trying to do? Why am I prescribing this medication? What's the agenda here? And nothing should be hidden. It should be all transparent. And we should develop these goal with a collaboration of a child and their parent or caregiver. And these target goals or these outcomes should be very realistic. They should be achievable. They should be measurable. And we should be able to change them. That's okay. They may change over time. And the examples that I have is perhaps the reason for the treatment that you prescribe is to improve the relationship with a caregiver or with a teacher or siblings or peers. Example, a child will play without fighting at recess. And I do that for my adult population as well. Child will attend, or not child, my client will attend support group or whatever the case is, will attend that activity without fighting with the peers and so forth. So the second example I have is improved academic performance. So this can be measurable. You can ask for the grades and report card and so forth. And the third example I have is improved rule following. Example, the child does not talk back to the teacher anymore, or you can count the incident, the number of incident has been decreased. So see how these goals are realistic, they're achievable, and they're measurable. And if things are not things are not going into the right direction, you can always adjust the medications. All right, well, this slide, I know it didn't come that clear. It's very blurry, but anytime you measure something, you're supposed to use a standardized tool, some kind of a rating scale. It doesn't matter what you use, but as long as you are consistent with that, I think that's the key. So this was just one rating scale that is highly recommended, I should say, for assessment and monitoring of ADHD. Okay, when do you refer? Now, it depends on your setting. If you are working as a primary care, then of course there will be a time for you to ask for help or send a referral. But if you are working as a psych mental health professional, then you are the you are the specialist, and then you are going to get those referrals to your clinic, right? So generally speaking, when you have a child with ADHD between 4 to 18 and they do not have any other comorbidity, those conditions are usually managed or can be very well managed by their PCP. Um, However, if all of a sudden a child is not responding well to the treatment that you have, or has a poor response, or the other coexisting psychiatric condition, maybe the child has ADHD along with ASD or something else, maybe child has a substance use, seizures, tics, then at that time I think that requires referral or consultation to healthcare, mental health care professionals. All right, so that's ADHD. That was a definitely longest section, but I'm not going to spend too much time on number 5 and 6. We're almost done. Um, Number 5 is a specific learning disorders, and as name implies, the child is going to struggle with the learning. So you have so criteria A is you have at least one of the following symptoms for the past 6 months, and these symptoms are uh, very self-explanatory. You have a child who has a difficulty with reading, understanding meaning. Maybe they can read, but they have no clue what they're reading. They have difficulty spelling, difficulty with written expression, um, difficulty with math, so mathematics, numbers, and so forth, reasoning. Okay, so just take a look at that. Number 6 is motor disorders. You have a client who has some kind of a repetitive a motor behavior, either handshaking or body rocking, self-biting, and so forth, that interfere with ADLs, of course, and put that child at self-injury, or Tourette syndrome, which is tic. A tic is a neurobehavioral condition, where you have a child with repetition involuntary, so that's a key word. They're not doing it intentionally. It's not voluntary, it's involuntary, either a motor or a vocal tic, one or the other. So for example, a motor tic would be like a quick jerky movement of the eyes or face or shoulder, or sometimes you have a vocal tic like a grunting throat, like a throat clearing. That is going on for the past 1 year. And the onset is before the age 18. That's a key word here. All right. You will come across a transient tic, very common in school-aged children, age onset 7, and more common in boys than girls. And of course, symptoms will last for more than 1 year or so. Now, most of the time, to be honest with you, it does not require any treatment. It requires just maybe reassurance. And if you have to treat, or patient teaching would be teach about habit awareness, reversal training, like self-awareness, acknowledge that and work on it. How can you reverse that habit, if you will, right? Plus minus clonidine can be given, or even antipsychotic can be used if the symptoms are overwhelming and has impact on their day-to-day routine. Haldol and risperidone are commonly used to treat these symptoms. And make sure we rule out some other issues such as cocaine use and Huntington disease. We'll talk about this later on in other lectures. And we're almost done. Number 7 is other neurodevelopmental disorders. And by other, we really mean when you have a client who is giving you all the symptoms, and of impairment in social and other settings, but they are not meeting the full criteria for any of the disorder that we have talked so far. So what do we do with that child? They have the symptoms, they're not meeting the criteria for any of the one that we talked about, so we classify them as other. And sometimes when you don't have enough information, in case of emergency, you don't have time to make a specific diagnosis, we use unspecified. Anytime, I personally believe as a healthcare providers, especially if we are the primary, we should be able to specify things. I have seen diagnoses such as lower extremity edema, unspecified extremity. Well, when you were assessing the patient, you should know if it's a left or right, otitis media, unspecified. Well, we should know that, right? Especially the site. Same thing when I see a patient, maybe in the beginning I'll say unspecified psychosis because I don't know if this is just one episode, or is it a schizophrenia or substance use issue. But if I have that client with me for a month or so, I should be able to change that from unspecified to something more specific. So I think we are responsible to really clean up our diagnosis list. All right, I think that's enough for today. I will leave you with this, with a lighter note, if you will, that there's no one textbook on how to raise a child. I truly believe it takes a village. Here, you're saying that I attend as many parenting classes as I can, anything to get away from my children. I think caregivers, they're trying their best to raise their children, and we as healthcare providers, we should acknowledge that, appreciate that, and be their partner, and try to bring that positive change in the community. All right. Well, just as usual, if you have any questions, concerns regarding any of the lecture, any of the topic, please do not hesitate to email me. I know that most of you do all the time throughout the week, and I appreciate that. I love that collaboration. So continue to do that. I will see you other time. All right. Thank you.